My name's Harry Rutter. I'm an academic at the London School of Hygiene and Tropical Medicine, and I'm the Specialist Advisor on Obesity to Public Health England. In my previous job, I set up and was director of an organisation called the National Obesity Observatory that is now part of the Knowledge and Intelligence team within Public Health England. The aim of the observatory was to provide a single point of contact for data, evidence and other resources to support people working around the country in policy and practice to tackle obesity, unhealthy diets and low levels of physical activity. One of the main areas that we realised that we were told people wanted support in was in evaluating weight management interventions. And in response to this, we set up a programme of work to develop resources to support people in conducting these kinds of evaluations. We started with this document. It's called the Standard Evaluation Framework for Weight Management Interventions, or SEF, Standard Evaluation Framework. And it's broadly in three parts. First 20 or so pages provide general guidance on how to conduct an evaluation, how to develop a logic model for your intervention, identify what its objectives are, and so on and so forth. In the middle, we have 2 pages with a set of essential and desirable evaluation criteria. These are the things one needs to measure. As you can see from this slide, there's a column of essential criteria marked out in orange and desirable criteria marked out in grey. So, for example, the description of the intervention, the target population, content, delivery method and so on are essential criteria. Without those, you can't say very much about what's going on. Whereas perhaps things like the core staff competencies and the incentives that were provided for attendance, if any, they're good to know about, but they're not absolutely essential. And what this reflects is the kind of tension that we experienced when we were putting this document together with stakeholders, in that there was a huge range of people that we were trying to support here. This was potentially of use to academics who might want to do rather detailed work, but equally there were practitioners who were being asked to evaluate their interventions in the midst of a busy job trying to deliver it. So we couldn't ask everyone to measure everything. So this was a pragmatic balance that was agreed between this wide range of stakeholders. The second page of the 2 lists another set of essential and desirable criteria. So we need to know something about the demographics of the individual participants. What age are they? What sex? What ethnicity? But other things such as perhaps the specific methods of data collection and the timings with which that was done were very good to know, but we didn't say that those things were absolutely essential. The third part of the guidance, 20 or so pages at the end, was a detailed description of each of the items listed here in the tables of essential and desirable criteria to give much more guidance and support to people who might want to know how they would measure these things, which could be anything from the kinds of tools that might be used to assess physical activity to the ethnicity codes that would be used within the data collection setup. This guidance was very well received, and we had a lot of pressure to develop wider guidance, not just on the specifics of weight management interventions, but also more broadly on interventions that focused on diet and other guidance that looked at interventions that were intended to promote physical activity. So we ended up with a suite of 3 documents, SEFs, Standard Evaluation Frameworks, one for weight management interventions, one for dietary interventions, and one for physical activity interventions. And these documents are still available on the Public Health England website. My sense is that they have been part of a real shift in the ways in which evaluation is regarded within this field of public health. When we first started out, we were getting a lot of people asking for these things, but we were also getting a little bit of resistance from people understandably saying, I've got enough on my plate, I can't do this as well. Whereas by the end of the process, we were getting many more requests saying, come on, we want some support for this. We want more guidance. Where is it? And that has continued. These were just part of the process there, and that has continued since. I think that over the last 10 years or so, there's been a real burgeoning in the in interest in the need to evaluate the interventions that are conducted and learn from them. And of course, it's vital that when we do interventions, we learn from the success of those interventions. If something's working, we want to know, and we should be sharing that information. But at least as important is to know when things don't work, when they're not effective. And actually, I think we should celebrate failure in this sense as much as we should celebrate success, because it's useful to know what works and what doesn't. And we shouldn't only look at one side of that equation. My thinking has come on a long way since the early days of starting work on the standard evaluation frameworks. The Obesity Observatory arose as a result of the 2007, the work conducted towards the 2007 Foresight Report on obesity, which really brought to the fore the idea of complexity within health problems, defining obesity as the outcome of a complex adaptive system. When we conceptualize obesity as a problem that arises from a complex system, that has a lot of implications for the ways in which we should respond to it, including the ways in which we should evaluate interventions. There are many dimensions to this, but one of them is to move away from this idea that we should expect a linear chain of cause and effect. So do an intervention and get an expected outcome. And in fact, think instead of interventions to tackle obesity as causing realignments, adjustments, shifts within a complex system with many, many factors influencing the outcomes. There are lots of ways to describe this, but one of the ways in which I like to explain it is to talk about the difference between things that are complicated and things that are complex. Here's an image of a Saturn V rocket. That's a very, very, very complicated piece of equipment. But if we knew what to do, and people in NASA do, you can get all the bits together, you can find the instruction manual, you can make all the pieces, you can put them together, and then you can put 3 people in that little cone at the top, send them to the moon, and you know exactly, to within very tight tolerances, where they're going to come back and when. So you send them off to the moon, and you know exactly where to collect them from when you pick them up in the ocean a few days later. So it's a very, very complicated system, but it's extremely predictable. It's manageable, it's controllable. You press a launch button and you know what the outcome is going to be. Geopolitical relationships in the Middle East, however, and you'll be pleased to see that Palestine and Israel were discounted for the sake of simplicity, present a rather different kind of challenge. This is a representation of a complex set of problems, of a complex system. And the point here is that there isn't any one simple linear chain of cause and effect. Wherever one intervenes, there are widespread ramifications, which isn't the same that there's nothing that can be done about improving geopolitical relationships in the Middle East. There are many things that can be done, and of course many people try, with extremely variable results. But the fundamental point here is to see that this is a different category of problem. This contains feedback loops, it contains emergent properties, it contains the characteristics of a complex adaptive system. And this is the Foresight map of obesity that came out of the Foresight project that illustrates obesity as a complex adaptive system. The main point of this map for me is that it's really hard to make sense of it. The main point of this map for me is that as a problem, it's the same category of problem as the one I just showed of geopolitical relationships in the Middle East. So broadly, the left-hand side on this represents dietary factors, the right-hand side represents physical activity, The top quadrant represents social, cultural, psychological and other factors, and the bottom quadrant represents physiology, biology, genetics and so on. And then the ring in the middle is the positive feedback loop of energy balance, in which we're programmed, having evolved as hunter-gatherers, to consume energy when we can find it and conserve it in case of there not being enough energy around. What this shows us is that we shouldn't expect any one intervention in any one small part of that map to change the whole thing. But all too often, that's what we look for. What this has revealed is a problem with the ways in which we think about evidence in the context of a complex adaptive problem, system problem, such as obesity. When we think about obesity as a complex system, it can help to explain why we haven't made very significant progress in terms of the evidence base about what to do to tackle it. So here's a very basic slide that I put together when I first started working in the obesity, showing where I hoped the evidence trajectories would go. And if you look at the red line, that represents interventions that are based on hunch, on good ideas, sensible, appropriate theories. And when a new field of knowledge arises, that is, of course, where you start. You come up with a theoretical basis for doing things. And over time, you evaluate them, you build them into research programs, and you do fewer and fewer of them because you've learnt from them and generated evidence, and then you do more and more evidence-based interventions. Unfortunately, for obesity, we've moved a bit along to the right, but we haven't made a great deal of progress. It seems to me that there are quite a lot of reasons for this, but one of the main reasons is because of a failure adequately to grasp this problem of complexity. If we imagine an olive, it's really just a Venn diagram, but bear with me. If we imagine an olive, big fat juicy olive, the flesh of that olive represents all the interventions you could possibly do to tackle obesity, for which we probably don't yet have any robust evidence. So if you were to write down your top 5 things that we don't know for sure will make a difference, but sound like good ideas, the hunch-based things, that's what sits in the flesh of the olive. The olive is stuffed with a pepper, and the pepper is the subset of those interventions for which we've got some evidence of effectiveness. And the pepper is stuffed with a very small piece of garlic, and the garlic represents the interventions for which we have evidence of effectiveness, for which we also have evidence of cost effectiveness. Now, in cash-strapped times, common sense would tell us that the obvious place to focus in this olive of evidence is on the garlic, the things that we know are cost effective. But this is a dangerous olive because focusing there carries risks. This is a diagram from a 2011 Lancet paper by Boyd Swinburne and colleagues. Broadly, what it shows is a range from left to right of, on the left, big picture, upstream, policy type interventions, fiscal measures, sugar taxes, reforming agricultural policy. Perhaps most upstream of all would be a really meaningful high-level carbon tax. On the far right-hand side, we have individual level treatments. Again, the best example of this would be bariatric surgery, surgery for obesity. And in the middle, we have a range of environmental factors. So that might be the kind of environment we have on the streets to support walking and cycling, or restrictions on fast food outlets near schools. And very, very broadly, the left-hand side of this diagram represents the kinds of interventions that are the responsibility and where the opportunities to act sit with national government. The area in the middle is broadly where responsibility and potential sits with local government, and the far right-hand side is really around the health service and the health sector. And if we look across this range, what we see is that there's a wedge at the bottom labelled population effect and political difficulty. So on the right-hand side, we have things like bariatric surgery. hugely effective intervention in the right people. Excellent, excellent, excellent intervention in the right people. But we do around 6,000 bariatric surgery operations a year, and there are around 1.4 million people in this country with a body mass index over 40. It's not a perfect measure of need, but it gives a level of indication. So we have an intervention that is extremely good at individual level, but almost irrelevant at population level. We couldn't possibly do enough bariatric surgery for that to be a population level intervention. At the other end of the scale, we have things like sugar tax is the best example, but agricultural policy reform and so on and so forth. Those things are politically quite difficult to do, but they potentially have very big population level impacts. And I've added 3 more wedges across the bottom: evidence base, public, media and political discourse, and political mandate. And this is where the olive point comes in. Because the thing about the olive is that the interventions for which we have evidence of effectiveness, and even more so the interventions for which we have evidence of cost effectiveness, tend to be, not exclusively, but tend to be on the right-hand side of this diagram. So the evidence base that we have is hugely skewed towards the individual level interventions, which in general are not the ones that have the large population level impacts. We also have public discourse that tends to focus on individual responsibility as a main driver of obesity. And as a result of that, inevitably, the politicians have a political mandate to act on that side of the equation. So this is the reason the olive is dangerous. If we pursue where the evidence base leads us, it tends to drive us to do things that we can measure, on which we can generate evidence, but which may not be the most effective and most appropriate to generate large-scale population health improvement. Mayor Bloomberg, when he was mayor of New York City, did many extremely useful things, extremely positive things to tackle obesity. And one of the things he did was to try and ban these giant soda containers. I can't remember exactly how much is in them, but a large quantity of generally sugary drinks in a giant cup. And he failed on a legal technicality to achieve this. But one of the big areas of pushback from the industry was to claim that banning these giant cups of soda, sugar-sweetened drinks, they claimed there was no evidence that this would cure obesity. And this is an illustration of how we've created an environment in which the wrong questions are asked of our interventions. We shouldn't be asking, does this one single, fairly small-scale intervention on its own fix the whole big, messy problem? Instead, we should think about tackling obesity more like putting together a jigsaw puzzle. And the number of pieces in the puzzle depends on the size of those pieces. If we use really big, powerful upstream measures, it doesn't need to have too many pieces. We can make it a fairly simple puzzle. But if we do, as we are doing appropriately, a large number of much smaller scale interventions, what we end up with is a 1 or 2 or 300 piece jigsaw puzzle. And we shouldn't expect any one piece of the puzzle to solve that whole picture on its own. So instead of asking, does this intervention solve the problem? Does it fix the problem on its own? Does it work? We should ask, does it contribute? Is it a piece of the puzzle? Does it do more good than harm? Does it have any unintended consequences? If so, what might we do about them? Are there perhaps some things we should do first to make this more effective? Might there be some other things we should do afterwards to potentiate its effect? And so on and so forth. And if we make this shift from does it work to does it contribute, we shift the nature of burden for evidence that we place on our interventions. Now, that's not for a moment to say that we should just assume that everything's good and get on with it. We need absolutely to be objective and scientifically robust about assessing the effectiveness or otherwise of the kinds of things that public money gets spent on. But we need to do it in a way that is realistic and appropriate and doesn't just dismiss interventions because they failed to achieve something they could never possibly have hoped to achieve. There's another side to this, which is to take a systems approach to the kind of impact that interventions have. So if we think about something such as a walking school bus, where your children are dropped, I don't know, maybe a kilometre away from school, and they walk from that location in a large group with teachers accompanying them to the school itself. Now, on the face of it, that intervention, those kids might burn 20 or 30 calories making that walk. Big deal. Well, first of all, if you can find 9 or 10 other things in which they can burn 20 or 30 calories, that actually is a big deal. The apparent primary purpose of this might be to get those children to expend more energy, but actually it might have much more important secondary effects across a wider system. So sure, those kids will burn 20 or 30 calories, but they also get habituated to the idea of walking whatever the weather. They have parents who get used to the idea that their children will walk to school whatever the weather. You might have fewer parents driving up near the school, which will make the environment near the school a more pleasant place for people to walk or cycle. And you'll get a group of parents who want safe streets on which their children can walk, and that might change the kinds of things that happen to the local environment in that area. So there's a range of wider actions impacts across the system that can come from an intervention like this, it's hard to assess them robustly, it's hard to measure them objectively. But if we take a system approach to conceptualizing the intervention, we can see how there might be a range of other things that might come from an intervention like this, and perhaps we could design it in order to maximize those effects. So if we come back to the foresight map and think about the ways in which we can respond to obesity, we can start by perhaps doing a few interventions on the food side, or perhaps some on the physical activity side. And then we get a bit better at it and we do interventions around the whole system. And then we get really good at it and we do lots of interventions across the entire system. Do diet, physical activity, social and cultural stuff, some biological stuff. You put it all together. But what this image represents is still a large number of discrete interventions. And actually it's only when we combine them and genuinely think about acting across the whole system itself that we can really start to potentiate the effects and get them to build on one another and ultimately have a much bigger impact on the fundamental problem. I think it's also really important to appreciate that it has taken us several decades to get into the situation that we're in now, and we shouldn't expect it to reverse overnight. It's going to take time. There's also, I think, an important need to recognize that there are some activities that are like building the foundations of a building. When a large office block or tower block is built, a significant amount of time is put into building, digging a big hole in the ground and building really solid, strong foundations that can then be built on. But once the building is in place, you never see them again. And many of the things that one needs to do in the early stages of responding to a problem such as obesity may be like building the foundations of a building. Really, really important, but very hard to see what the impact is later, except that it's been built on. This slide shows the trajectory of tobacco sales, tobacco consumption in the United States across the 20th century. And what we see broadly is a steady rise up to about 1960. The line then sort of bounces around the top for about 20 years before turning a corner and starting to decline. Now this is tobacco consumption, this isn't obesity, but it's a pretty standard representation of the shape of an epidemic. This is what epidemics generally look like. And I think what's instructive here is that there's no one event, there's no one thing that led to tobacco consumption, cigarette consumption levelling off, and there's no one thing that got it to turn the corner and start to decline. Instead, what we see is the gradual accretion of large numbers of things over time that eventually shift the shape of the trajectory and move the trend from upwards to horizontal to downwards. And I think we should expect to see the same kind of thing with obesity. This isn't going to get solved overnight. We shouldn't expect any one intervention, including the sugar tax, to lead to a drastic change in the shape of the curve, because it's a complex adaptive system. And one of the words that gets forgotten there is the word adaptive. When we put interventions in place, the system adapts to them. It's only when we have a large number of responses in place, a large number of pieces of the jigsaw puzzle, that those adaptations become limited and we really start to see change. But if you only intervene in one part of the system at a time, then the system just realigns around it. And ultimately, by adopting these different ways of conceptualizing the problem, developing existing and new tools to improve the ways in which we can evaluate them, and explaining clearly what we mean by a system problem and why there is a need for midstream and upstream responses, at least as much as downstream responses, what we could ultimately see is a rebalancing of the distribution of our responses, the actions and interventions that we take. I'm not for a moment saying we should stop doing the individual level actions. Of course we need to continue them. It's the balance that's wrong. And we need to match the activity that takes place at that end of the spectrum with a much wider and larger level of input further up the system. Changes to the physical environment, changes to the policy environment, changes to the fiscal environment. And over time, I think we will see these shifts, and that's when we might start to approach a real shift in the shape of the trend. So, to conclude, we have some really useful resources to support evaluation of weight management, dietary and physical activity interventions. They provide guidance on how to conduct the evaluation, they give advice on which data to collect, and some detailed guidance on the specifics of those items of data and how one might collect them. And I think they're useful tools. They've I hope, made a useful contribution to improving the number of evaluations and the quality of those evaluations over the last few years. But I don't think they're enough on their own. And along with using tools like that, I think we also need to think in quite a nuanced way about the importance of context and complexity here. And just because it's not that easy, but it's relatively easy to look for linear cause and effect, it doesn't mean we should always do so, because it may be misleading. And it may be that the system impacts of an intervention are at least as important as the direct impacts. And I think if we continue to treat complex systems as simple, we're going to be continually frustrated that it looks as if many, if not most, interventions don't work in the traditional sense of the word. But that's because we're judging them on the wrong criteria. And I would argue that one of the most important things to do is move from this question, does it work? Does it solve the problem on its own? To, does it contribute? We have guidance on evaluating complex interventions, but we have very little so far on evaluating simple interventions within complex systems. And I think that's one of the places we need to go next. Thanks very much.